Thank you very much, and thank you, Dr. Callahan, for inviting me to come speak. It's an honor to be here today. So today I'm going to be talking about just the systems approach, and I'm not a researcher, but I'm one that uses research in my practice, and I'm the boots on the ground, the person that was working in the facilities. Mostly I'll talk about healthcare because that's the majority of my background. I'm a physical therapist, and how I got started and what I learned in building programs as I went along. So, let's see. So here are the learning objectives that we've got. And just talking a little bit, a review of what is a system and the systems approach. And then the key components of what I found to be important in ergonomics and safety programs. And I'll give you a little bit of my trials and tribulations that I've gone through in producing those type of programs. And then recognition of guidelines, like your wonderful MSD guidelines here for Ontario and others that can be integrated into your program and why those are so important to have that. So what is, a little bit about what is a systems approach to programming. First of all, we need to understand those three categories of ergonomics, which I'm sure you're all familiar with. So you've got your physical ergonomics, dealing with those MSDs, and then your cognitive ergonomics, which has been talked about a lot this morning with your psychosocial and different things that come into that, stress and workload, how does that affect those MSDs? And then your macroergonomics, or your systems approach. So that's really the focus of looking at this. How do we look at the structure of an organization or consider that, and what are those key components that come into your programming? So this is your basic picture of what a system should be. You have your person that's always in the middle of the system because they're affected by all these things that are revolving around it. You have your tools and technology, depending on what type of organization that you're working for. Those affect the person, the tasks that they're doing, of course. You have your internal environment. Do you have weather? Do you have noise? Do you have whatever it is physically that's affecting the person in that environment? And then the organization itself. Now in healthcare, it's typically been a pretty vertical, hierarchical organization. Other organizations are going to be more horizontal and have a little less of that hierarchy. So that's going to affect that psychosocial effect too, and a part of the system and the outcomes. So this, I love this, is the SEEPS program we have from Carry-On, and she developed this out of a lot of the early human factors research and developed it for healthcare. And what's unique about this system that she did is that it stresses more the outcomes that come out of a system, how they affect that person in the middle and how they play back into the organization itself. So in healthcare, again, you could have that person at the middle be a patient, or it could be an employee. So it can be either of those things that is affected and has an outcome because of the errors in the system and the problems that you encounter. Now, looking at a larger system, what was typically done was assign blame a lot instead of really focusing down on which of these pieces of the system is failing. And I'll try to point out what I found when I went through with some of my programming and how that came out. So I'll back up and I'll tell you a little bit about my background and how I got started. I worked for a large healthcare system. And I was a physical therapist. I kind of went through all the different departments of working. And then, because it was in a hospital system, a lot of the employees would come in to me for treatment. And, you know, they'd tell me, oh, gosh, I feel so much better after you've treated me. And I go home for the weekend or whatever. And then I come back to work, and I'm hurting again. So that really got me piqued for thinking about prevention. How can we stop that pain before it even starts? And that was the big challenge. And I'd start visiting the departments and go out and get involved. And then in Washington State, where I'm from, this slide shows you a little bit about the progress of where we were at and our thinking and how we started developing these programs there. So in 1997, California had the first and only ergonomics rule in the United States. It's not much of a rule, but it is a rule, and I'm pretty proud of California for having that. And then Washington State got on the bandwagon, and in 2000 had a very short-lived ergonomics rule, unfortunately. People didn't really understand ergonomics at that time, and so it was pretty easy for them to repeal that in 2003, unfortunately, and the same thing happened with the United States rule for ergonomics. It was very, very short-lived that it came in. But at the same time, Washington State had a task force for safe patient handling for the hospital systems. And so I jumped into that and started getting involved and thought, how can we really start addressing these MSDs and using those programs to our advantage? And we'll talk a little bit later about the importance of having some of those laws. You don't always need that in some situations, but having guidelines and regulations can really help assist your program. So in 2006, we were the second state in the nation to have a patient handling rule, and I believe now there's about 11 states that have a safe patient handling law that helps them out. They're not all created equally. My last job, I was working down in California. They have an excellent law. It really it was a little bit later coming in, and it ticked all the bases for what they needed to consider, including the right to refuse when you felt you were at risk. So my first place that I landed as a physical therapist was Swedish Medical Center in Seattle. At the time I joined, it was only 2 hospitals, First Hill and Ballard, and then we became involved in a very rapid growth period where we acquired different hospitals, and we built a lot as well. So this was a good time for developing these programs, but it was also challenging because we're not only looking at a system of one hospital and one culture, but even though we were in the same region, they were all coming from different backgrounds. And so that system I talked about was complex, and being able to address all those things and bring us together as one organization. But it was also a good timing to start a program for patient handling and ergonomics and get that in there. A lot of times I'll talk to different people and they'll say, well, healthcare's kind of basic. I would counter that. It's a very complex system, especially in a large hospital system. You've got many different departments which can be systems on their own because they're dealing, like in your ultrasound, your imaging department, different types of equipment that they're using under different protocols. Patients coming in as outpatients. You've got pharmacy, sterile processing, the nursing on the floor, and the OR, which can be very complicated in there. But it's also the same thinking in terms of certain programs, so with your ergonomics and your patient handling, how do we prevent those MSDs and how do we have a policy that's going to address everybody and how do we get that to work? So here's an example of one of the things that I encountered in a system problem. So with the patient handling program, you have a lot of ceiling lifts and floor lifts and equipment ideally that you'll be using. The slings are a component that goes with the lifts, and without the slings, you can't do your job. So the slings are pretty mobile. They disappear, they go through the laundry, and when they're not there, then it's an issue. So I would get reports back. I was leading, I went out of clinical practice and went into managing the programs of ergonomics and patient handling, and I'd get these calls from the floor saying, you know, nurses aren't using the equipment. And there we go, we're back to the blame again. You know, it must be the nurse's problem. They're not embracing this program. But you go up and you do the audits on the floor, well, where are all the slings? They've disappeared. And so I'd go out and I decided I need to look at the bigger system, the external system of what we do with these slings. So we had a laundry co-op, which was responsible for many hospitals doing slings. And when I went to watch them unpack these, I found at the bottom of their unpacking line what I like to call the lost and lonely pile. And this is where I found a ton of slings. the blue material there. It's one of our bed slings. They're very expensive. And so it got me thinking, you know, this is not working. We've got to do something to intercede in the system. We've got to get a hold of the vendor, the outside vendor. We need labels for our slings so we can identify our hospital, and we need a better process within. So this was one area that we addressed, as well as working on site with the managers to say, okay, we now have these slings under control in terms of bringing them in. It's up to you now to embrace this, to engage those employees. So like we had 3 floors of ICUs in the main hospital, and I contacted the manager and we said, let's come up with a good name. We said, let's get back in the sling of things. We had a spring sling, and we got the employees laughing about it and engaging in it. And I can't say, you know, it was 100% successful, but it did help. And the other thing that helped was looking at another issue, which was the second picture down here. I apologize, it's kind of an old picture, but again, they said, oh, there's no slings in storage. And what I found was someone called me and said, go up to the 8th floor on the dialysis floor, look in the old shower room. And I was horrified when I opened that door because I realized that the environmental services people didn't know what a sling was or what to do with it. They started dumping them there. There was a mountain of slings. So again, another system problem. I didn't engage those workers to be able to explain, what is this? Why is it important for employees? And, you know, can we make you a part of this system so that you're able to you know, fix this? So, you know, it's important to audit your programs. We all know that. And it's also important not to assign blame, to really find the issues. So my lessons learned for working in that organization were you need to have that executive support. Without that, going way up into your C-suite, that's where we needed to really make a difference. At one of the public speaking events we had on campus, we actually got, I think it was the CFO at the time, and put him in the lift and wheeled him out on stage for him to demonstrate that he thought it was a great thing and he was good-hearted about it. But getting their name on the policy and getting them involved is important. Having a policy in place is also really important. It helps hold people accountable. And if you have that person's name on that policy, you can go back and hold your administration responsible as well. Find out who the movers and shakers are in the organization, involve them in your committees, and understand those different cultures and biases that, especially when you have a larger system with multiple hospitals, to be able to engage them, accept some of their ideas, and bring them into the fold. And last but not least, and this is a reoccurring theme, I think for any organization, and Dr. Moody touched on it, is that your data management, a lot of these MSDs fall under sprains and strains. So you need to have a better system for organizing your data and get categories of injury nailed down so that you can analyze it and be able to go in. And as far as I know, in the United States anyway, we still don't have a consistent method for doing that across industries. And that makes it very difficult when you're trying to compare yourself to somebody else because you're not really speaking the same language unless you can drill it down to the exact cause and what type of injury it is. The next organization that I went to was Providence Health and Systems, and they bought out the Swedish system, and so now we were even bigger. And at the time that I worked for them, it was 34 hospitals in 5 states and about close to 80,000 employees, and now it's much bigger than that. I think it's doubled, Providence St. Joseph's, and that's sort of the trend in healthcare, as a lot of the organizations are banding together. And all of these, they called them ministries or hospitals, all had their own system of how they work. They didn't communicate together. So my role was to come from what I had developed at the Swedish system and develop this in 5 states with a very small team. That's always the problem, is getting your resources together. But it was interesting, and I learned a lot in doing this. Quite a difference in all the different states and how they operated, but it was good. I had some wonderful employees that were able to help me bring the program together. And what I learned in this organization is it's interesting where your program falls within an organization. And as a leader for what you do, you don't always have control over that. I was lucky at Swedish. It fell under the safety department, which was a perfect fit, well supported. This was well supported too, but it was under HR, which was a little different for me. I would say, you know, if you can get in the like-minded group to be able to support your efforts, the stronger you can be to have those advocates that are with you. The other thing is one size doesn't fit all. You've got to really be flexible in considering other programs that have been in existence and trying to work that into what you're doing, so you're giving respect to the other organizations. Again, data is a really big issue, use of the leading instead of lagging indicators so that you can get what you want. And then my last one was you don't always get what you want, but if you try, you might get what you need by just having patience, diplomacy, and compromise. I just threw this in here because if you're not as familiar with leading and lagging indicators and how to go about using them, this is an excellent resource. It's in my references, and I highly recommend it. And then the last, one of the last things that I worked was at Amazon for about a year, very different than healthcare. But I took a lot of things from that organization too that were helpful and understanding. In 2017, when I worked there, they were under a tremendous growth period. I think they increased by 44% when I was there, and then they continued to just keep growing and growing. So these were the main areas in the warehousing that I was concerned with. The challenge there was that there were, at that time, a lot of the legacy or the older warehouses, and then they kept building new as they're expanding and expanding. So it was a changing template for what ergonomics looked like and what the workstations looked like. And that made it really challenging. There were some wonderful folks I worked with there who met weekly and discussed how they were implementing change at each warehouse. And so they did the best they could to kind of, you know, Band-Aid it together, keep it going. And then now I understand it's more that they're going back and revising some of those older warehouses. But working in a changing environment like that can be quite hard for program management. Of course, I learned that time is money, and anytime you suggest an ergonomic improvement for MSDs, you better make sure that it's not affecting that delivery of the package to your house because, you know, time is money and that takes away from that. So efficiency, of course, in this industry, very important. The challenge of global programming is even bigger. I think at the time I was there, I was one of 2, maybe 3 people globally that had my position. Since there's been a large hiring and a lot more people have been brought in, which is good. It was very interesting understanding what had been done prior and how all these people were trying to pull these programs together. And then it was, I think we'd had some outside consultants come in. Any system, I kind of feel like it's really hard unless you've got somebody to mentor you within the organization to walk you through those system problems and the understanding of what you're dealing with. So I think it was hard for maybe the people that did some of the work I saw to see that there was this problem with the legacy warehouses, that they were not being brought up to the where some of the other warehouses would be. So just, I think, a better definition of goals for consultants that you bring in and helping mentor them if they come into your organization, or embedding them in your organization, which I think works really well, and increased hiring. So the last job I did, and one of my favorites, was working for a healthcare insurance company. And this was in California. And so it was really an opportunity. And here I was an outside consultant because we had our book of business, which was hospitals, clinics, hospices who run thrift stores. That was new to me to understand that. And so a lot of things you wouldn't think of when you think of healthcare. But we came in as the outside consultant, being the insurer, and we would encourage program development for these organizations. What we did was we designed what we called toolkits. And these toolkits encompassed ergonomics, manual material handling, safe patient handling, a SHARPS program, workplace violence, and I think they've since added others. We took and developed all the key components like you have in your MSD guidelines and put them in a packet of sorts. And then we had, like the MSD commitment, where people had to agree to sign on to these toolkits, and you had to have somebody from the C-suite whose name would appear in the policy and who had to sign off on it. And it was a true working commitment with this toolkit. It took anywhere from about 18 months to sometimes up to 3 years to complete this toolkit. And we had a validation checklist, which they didn't get to see at first, but we mentored them in all the steps and how to get through it. Came in and did audits, made sure that everything was in compliance. And then at the end, we actually surveyed employees. Do you know what ergonomics is? Do you know where your policy is? Can you show me on your website how to find it? And that was part of the validation process. So we really wanted to make sure we weren't just giving lip service. We were really trying to embed this program in there. And what we did find out, we did give them a monetary incentive, discounts on their policy when they completed this, but that alone did not ensure compliance and continuous process improvement. So that was a little disappointing. You'd go back maybe a year later and maybe that key person had left and some of the components were there. So now the program's being redesigned to extend it out a little bit longer and to have things in place to ensure that to continue to get the resources they need and the monetary incentives, they have to continue the program. So it's hard sustaining, and I think one of the hardest challenges you'd all agree with is finding that person who is going to stay with the program or having someone hired. That is probably the biggest conversation with organizations, is understanding that need, how complex these programs are, and it just doesn't work if you think, okay, manager Mary is going to wear 10 hats, and one of those is going to be program management. You have to justify it, so getting your data organized and being able to present that to management, looking at other factors that the leading indicators, like the surveys that have been talked about, the turnover rate of your employees, and in healthcare, that's a key one, right? In any industry, really, these days. So that was a big learning point. And get the mentorship, provide that mentorship. If you're an outside consultant, I think one of the best things you can do is guide people and instruct them how to get the education they need to run the program and be able to do that. So real quick, I know I'm running out of time, and most of the questions I'm going to be on the panel, so you can probably save them for them. And also, you can catch me at a break if you have more questions for me. But I just wanted to touch on the guidelines. There's guidelines, standards, and regulations, as you know, and they're all important. And the regulations, like in California, that we were uber regulated, but it really did help to be able to integrate those into your program and design your policies and procedures and reference these things so that you can always say this is part of the regulations in this state or province that you need to adhere to. And the standards are wonderful too because they're based on these things. So it's all good. I just threw together some different things that I've used over the years. Here's your MSD prevention program. The California Injury and Illness Prevention Plan, you can Google that online, and it's written into the California codes excellent. I think it's one of the best of any of our states, and it goes through all the key components, which I'll show you in a minute. Of course, your OSHA guidelines, the ANSI Z10, which is, you have your own version of that in Canada, the CSA Z4501, and they come off of the International Standards Organization for 4501. These are all programs that give you the basic tools. Like you were saying, Dr. Callan, and there's a lot of resources out there, many that you can use. They're all good. Great to go over those. And of course, we have our general duty rule, which when they got rid of our ergonomics rule in Washington State, we said, aha, we have that general duty law. So it triumphs over any of that. Same thing. Yeah, that's great. And then last but not least, safety culture, which has been touched on in the other talks this morning. I think very important, getting those surveys for that snapshot that gives you the safety climate. And then just culture. Are people familiar with just culture? Can I see with a show of hands? So some are. I really encourage you to look into that. And really this comes out of James Reason's work from ages ago and talking about reducing blame and having people be able to develop trust and be able to talk about, especially in healthcare with patient injury, being able to talk and tell what happened so that there's not blame. Very few people want to get injured or cause injury. So the people that are negligent are just a tiny fraction of what is out there. So Just Culture says you must build this into your system so that employees have trust. It affects the psychosocial side of things, and it can be a real win-win for your organization. The Just Culture company is a company, not to give credence to any one company, but that's one I'm familiar with in the US, and they have seminars you can go to learn. Here's my little list of, like, in your program and policy development are the key things. Responsibility and compliance, like we were all talking about. And the other thing is injury and hazard recognition. These are one of my favorite things to talk about. It's a whole nother lecture to go into that, but if most organizations are missing out on someone actually going out to investigate that injury and bring the results back, typically falls in a safety committee where people go, there's an injury, let's talk about that. Next month it comes up again and it's the same talk and no action. So having a system in place that's robust can really help you with that. And that's it. So, give it over.